We'll get started with the instruction course on Macula Unplugged. The goal of this presentation was to try and pack in as much information about the macula as possible, and we thought the best way to do that would be to break the lesions up into individual lesions such as yellow-white lesions, hemorrhage at the macula, fluid at the macula, etc. So before we get started, I would like to give a brief introduction of my colleagues and co-instructors. Starting with the youngest, Dr. Srinivas Joshi will be the opening batsman. He will be talking about clinical examination of the macula, and he is one of the consultants at the M.M. Joshi Eye Hospital in Hubli, and he has had a fellowship in Canada. Following him will be Dr. Mahesh Shanmugam, who heads the Department of Vitreoretina and Ocular Oncology at Shankar Eye Hospital in Bangalore. Myself, I'll be talking about yellow lesions at the macula. Dr. Lingam Gopal, who needs no introduction, the doyen of vitreoretinal surgery, he will be speaking on fluid at the macula detection and significance, to be followed by Dr. N.S. Muralidhar, one of the earliest surgeons to start serious retinal work in the state of Karnataka. He will be talking on blurred foveal reflex recognition and causes. And we may have a change in order there. Dr. Guru Prasad will be talking on sheets and striae at the macula. What do they indicate? May I now call Dr. Srinivas Joshi to please begin the talk on clinical examination of the macula, how to glean the maximum information from this.
Thank Dr. K. S. Kumar sir for giving an opportunity to be in his IC. Leave it. Yeah. So as he has already said, I am the opening batsman. So opening batsmen usually are pretty much slower, very defensive, and the trail ending batsmen are the one whom you expect more and more surprising videos. So just to go in more about the anatomical details, not moving. Just to touch about the anatomical background. So macula lutea is also called as the area centralis or the central retina or the posterior pole. It's a 5.5 mm circular area, deeper red than the rest of the fundus. So just for the interest of the postgraduates here, it's a 5.5 millimeter diameter. We have the fovea, the foveola, the umbo, and then the parafoveal region, and then surrounded by the perifoveal area. So the fovea centralis is specially differentiated from central macula. It's 1.5 mm in width and 0.25 mm in thickness. And its thinnest and the most sensitive part of the retina, the densest of the cones, are at the fovea centralis. It's absence of rods. And the taller RPE cells, thinner, and they are deeply pigmented. Xanthophyll, lutein, and zeaxanthin are responsible for the characteristics of the dark appearance of the macula. The special anatomy enabled for the fovea are the highest discriminative ability, that's the visual acuity and the color perception. So the foveola is 0.35 mm with a wide depression and devoid of ganglion cell, has only cones and Muller cells. So how do we examine the macula? Basically, we have the different systems. One is the indirect ophthalmoscopy system and the direct ophthalmoscopy system. I was instructed by the chief instructor to just tell a few advantages and disadvantages of IDO and the binocular slit lamp examination. So indirect ophthalmoscopic lenses, we all know the technique is called as indirect because the fundus is seen through a condensing lens and the image is formed in between the observer and the condensing lens. The usual normally interpupillary distance is about 60 mm and it is reduced to 15 mm by the prisms located here to get an image in between the lens and the observer. So the handheld lens acts both as a condensing lens for the illuminating system and the lens for forming and having an inverted image. So there are different kinds of condensing lenses, that is a 15D, 20D, 28D and 30D. They are basically for retinal magnification, field of view and stereopsis. So these are the different, as we know, as we go lower the number, higher is the magnification and lower is the field of view. So the advantages are larger field of view we get, it's useful in hazy media, can be used intraoperatively, and vitreous can be examined even though there are some vitreous abnormalities. But the disadvantages are it's less magnification, details of a small lesion not visually properly, and then it's more uncomfortable to the patients because of the bright light. So coming to the most important is the slit lamp fundoscopy, which is the only way to look at the macula, is using the different kinds of lenses, either the non-contact lenses, that is 40, 60, 78 or 90, and then there are a few list of contact lenses like Goldman contact lens, 3-mirror lenses, Mainster and pan fundoscopy contact lenses. With the slit lamp fundoscopy, we only see the slit image. We do not see the picture as a whole at one time. So we have to move the slit in different directions. And this is the images which we can get through 90 diopter, 60 plus 60 and plus 40. As we see, there's the magnification goes on increasing in this case of macular hole, and the field of view becomes decreasing. So slit lamp fundoscopy is a must, as I said, for the macular examination, for clinical examination, whichever you are comfortable with, either with a 78D or with a 90D. Fixate your arms comfortably using the armrest and the patient comfortably seated at the slit lamp with the pupils dilated. So here you see in the slit lamp biomicroscopy, you see the image is inverted here and laterally reversed. So a thin slit beam at 45-degree angle with high magnification, it gives, even you can see sometimes the cystoid spaces in cystoid macular edema and even the subretinal fluid in case of neovascular membranes. Just touch a brief about the contact lens. We use mainly nowadays in the laser. Nobody much uses it in the OPD basis, but of course the contact lens imaging is much more, viewing is much more better as compared to the non-contact lenses. But yes, it has its own advantages and disadvantages. You need a coupling fluid into the cup of the contact lens, and the patient is asked to look up. And if you're using the 3-mirror, then you have to rotate the lens for 360 degree, looking at the different parameters. So just the Goldman, the pan fundoscopic and the Mainster lens, you get 18 degree with Goldman, pan fundoscopic gives 60 degrees field of view, and then Mainster gives around 45 degrees field of view. The advantages are very high resolution and magnification. You can get a 3-dimensional view. Stereopsis is better, visual and erect image is obtained. The disadvantages are limited field of view and cumbersome to use. So these are the two different photographs you see here, the indirect ophthalmoscopy and coming to the 78D. You can see the macular edema much appreciated better in the 78D, but just you can see the superficial hemorrhages here in 20D lens. This was another case which after seeing through the IDO, we could get to know that there is some pigmentation here. And of course, there are some chorioretinal atrophic patch. Here is a case of high myopia. And then when I switched to 78D, I thought that looking at the IDO, I thought it could be a CNVM, myopic CNVM. But looking at the 78D, there was no subretinal hemorrhages or any vascular network there. Then I thought, okay, it could be a pigmentation. But anyhow, I told the patient to undergo OCT testing, which the patient was not agreeing. Then after a lot of counseling, then the patient did undergo OCT, and surprisingly, we could find out a macular hole in these patients. So what I mean to tell here is, just with the IDO, definitely you can't examine the macula. For the macula, you definitely need 78 or 90D. But sometimes, only with 78 or 90D also, we will not be able to find out the real. So the examination gets completed only when we have the high-end machines. So this is another case with the 78D lens. We can see the neovascularization of the disc very well. And this was another thing I wanted to explain is, when one of my fellows showed this case, he said, look at this. Seeing the slit, I couldn't see anything. I thought, okay, this could be a normal macula. But then after widening the slit, you can see there is some boundary here. Okay, this is the subretinal fluid. So just with a small slit, sometimes it might be possible you have to widen the slit to get a complete picture. But I usually love using indirect ophthalmoscopy to get a better view in case of patients with CSR. and this was the OCT picture showing the subretinal fluid. So good enough, the advantages are good enough view to check for the tears and RD as well. No lengthy training required and no discomfort. So this is the last one video I wanted to show, because my instructor was telling that sometimes there might be a chance where a technician who is doing the OCT can miss any of the lesions. Say for example, if there was any hard exudate, or if there was any small plaque which was missed on clinical examination, and if you don't tell your technician to do it on OCT, it might be missed. But there's a slight change here, is because nowadays with the advent of the eye tracking system of these OCT machines, you can see here the patient is just focused. You can see the raster. When she moves out, the scanning stops. And again, when she moves her head in, again the scanning continues. So there is no chance that there can be any missed lesions on the posterior pole with the advent of the spectralis or with the high-end machines. So just to end, the new layers have been added was possible only because of OCT. That is the interdigitation zone, ellipsoid, myoid zone. I think the topics will be covered in the next presenters. Thank you very much.
Thanks, Dr. Srinivas, for that nice elaboration on the clinical methods of examination. May I now request Dr. Mahesh to please elaborate on hemorrhage at the macula, how to detect and what does it mean. We'll have a short discussion at the end if time permits.
I thank Dr. Kumar for giving me this opportunity to meet you all this afternoon. There is a pretty basic talk about when we look at a hemorrhage at the macula, what it means and how we go about distinguishing one cause from another. So we'll go layer by layer. So pre-retinal hemorrhage is a hemorrhage which is there in front of the retina, and usually the patient complains of visual symptoms because it's obscuring the vision, and it's bright red in color, and it blocks the blood vessels. So when you look at them, it blocks the blood vessels. A subhyaloid hemorrhage is the one which forms the fluid layer, which is boat-shaped. A sub-ILM hemorrhage is usually immobile. So this is a subhyaloid hemorrhage. The causes could vary from a simple valsalva retinopathy or to more serious causes like a diabetic retinopathy, in which case they can have a bleeding as well. In a simple cause such as a valsalva retinopathy, you can drain it by using a YAG hyaloidotomy. So putting a hole in the posterior hyaloid will make this hemorrhage drain down. But this is a sub-ILM hemorrhage. So this again can occur because of various causes like diabetic retinopathy or an accelerated hypertensive retinopathy. Or as in this case, there's a more sinister cause. There's a battered baby, which has what we call as the Terson syndrome. So in these, the blood is a little bit deeper, and so may not be able to remove it with the laser, and so may need a surgical removal. After opening up the ILM, you can remove the blood. So this is the same child, bilaterally had Terson syndrome with sub-ILM bleed, which was removed. So do we do any ancillary tests when we look at a pre-macular hemorrhage or a subhyaloid hemorrhage? The ancillary tests are usually not of much value, except for the fact it can give us a clue to what the underlying pathology is. For instance, if it's a diabetic retinopathy and we are missing a neovascularization of the disc, the FFA can tell us what it is. And at the site of the lesion, all we will get is a block fluorescence. And OCT can show us the thickness of the hemorrhage, so with which we can try to see whether we can wait and watch or whether we can try to do an active treatment. Coming on to the next layer, that's an intraretinal hemorrhage. Intraretinal hemorrhages usually do not cause loss of vision because they do not obscure the vision. And the blood vessels are most of the time you are seen, except for the fact that nerve fiber layer can obscure the blood vessel detail to some extent. Dot hemorrhages are the ones which are there in the inner nuclear layer, and blot hemorrhages in the outer plexiform layer. So this is a nerve fiber layer hemorrhage. You can see it takes the shape of the nerve fiber layer, radially arranged, and usually the causes are hypertensive retinopathy and some cases of diabetic retinopathy, or a patient with the early branch retinal vein occlusion can also have this. Nerve fiber layers with white center. So what we see here are the white-centered hemorrhages. They are a little bit more ominous. So these are the ones which we have been taught to say that the patients with infective endocarditis can have these white-centered hemorrhages. Patients with an infiltrative disease like a leukemia can also have these white-centered hemorrhages. Not all the time it means like it's an ominous sign. Even a patient with a diabetic retinopathy sometimes can have this white-centered hemorrhages. But when you see a white-centered hemorrhage, then we need to look for a more ominous cause inside in the body of the patient. So when we have to look at for other things in association with the hemorrhage. For instance, we see these hemorrhages in association, we see this hard exudates, and the blood vessels are of normal caliber, then we tend to think that's a diabetic macular edema. On the other hand, we find that the hemorrhages are localized to one quadrant, localized to a venous drainage quadrant, and the blood vessel there, the vein particularly, is dilated and tortuous, then we would tend to think of a branch retinal vein occlusion. Hemorrhages all over with the tortuosity of the veins and some soft exudates and edema, yes, these are the central retinal vein occlusion. So, and these, the central retinal vein occlusion, the hemorrhages can be nerve fiber layer, deeper dot and blot hemorrhages as well. So again, ancillary tests here in the acute stage of a vein occlusion, they don't tell us much except for the fact wherever the hemorrhage is, it blocks the fluorescence. But it gives us a clue. The blood vessel, the branch retinal vein or the central retinal vein which is blocked will show some amount of staining on the walls. And in addition, the other problem which we treat, that the macular edema, can be identified by doing a fluorescein angiogram. More often, we don't do a fluorescein angiogram in these situations now, but we do an OCT, which tells us that there is a macular edema and we need to treat. So this is what it shows, the blocked fluorescence because of the nerve fiber layer hemorrhage, and the cystoid edema as well as the neurosensory detachment when we do an OCT in this situation. But the hemorrhages as such are seen as the bright spots within the layers of the retina. So there are two situations where an intraretinal hemorrhage, we need to look for other additional things. So far we have been looking at retinal vasculature causing problems. So this is a sign of a intraretinal hemorrhage, but then what do we see here is a choroidal neovascular membrane. So parafoveal telangiectasia can present with intraretinal hemorrhage, but there will be an underlying choroidal neovascular membrane. So the OCT also shows a choroidal neovascular membrane. Similarly, a retinal angiomatous proliferation again also shows an intraretinal hemorrhage. So not all intraretinal hemorrhages are innocuous, but when you see an intraretinal hemorrhage associated with retinal whitening and elevation of the retina, we need to do a fluorescein angiogram to see if there is an underlying choroidal neovascular membrane and a pigment epithelial detachment, which is suggestive of retinal angiomatous proliferation. Subretinal hemorrhage is much more ominous. It lies underneath the blood vessels, so you can see the blood vessels clearly. So you can make out whether the blood is subretinal or sub-RPE. If it is subretinal, then the margins are clearly well seen and it's bright red in color. If it is sub-RPE, it's a little bit dull brown in color or dull red in color. Margins are not distinct. And in this situation, when we see any cause of subretinal hemorrhage, angiography and OCT is really essential. So as a patient of myopic macular degeneration, you can see a whitening here and a subfoveal hemorrhage. Do a fluorescein angiogram, shows the choroidal neovascular membrane. And OCT also shows a choroidal neovascular membrane. So this patient, you can see the color of the blood is a little bit dark red and the margins are not very, very distinct in contrast to what we see here. The margin of the blood hemorrhage is very, very well seen. But here, we don't see the margin of the hemorrhage very clearly, and it's a little bit darkish red in color. That means it's a sub-RPE hemorrhage. In association, we see the hard exudates. So this patient probably has an age-related macular degeneration, most likely a polypoidal choroidal vasculopathy, which is what we can see on the fluorescein angiogram and the ICG. ICG shows the polyp. So in this area, in this situation of subretinal hemorrhage, definitely a fluorescein angiogram and OCT is required. So this is again an example of a sub-RPE hemorrhage. You can see this is the sub-RPE hemorrhage, this is subretinal hemorrhage, bright red, distinctly seen. This is a hemorrhagic PED, the margins are not well seen. The hemorrhagic PED on OCT shows that like the light does not penetrate beyond that, will block it. So one lesion which gives rise to hemorrhage in all the layers is usually the retinal macroneurism. It can give rise to pre-retinal hemorrhage, intraretinal hemorrhage, and as well as the subretinal hemorrhage. This is a fluorescein angiogram of the same. So to summarize, hemorrhage the macula is an important clinical sign. It may indicate the presence of an underlying serious systemic disease. Morphology as to where it is gives us a clue as to the location and etiology. Angiography and OCT in select situations is necessary. Thank you very much.
Thank you very much, Mahesh, for that excellent elaboration on macular hemorrhage. Admittedly, these lesions don't occur in isolation, as we are all aware, but we thought of breaking it up into a lesion-wise discussion so that we can cover a whole lot of macular pathology. May I now request my teacher and the doyen of vitreoretinal surgery, Dr. Lingam Gopal, to please speak on fluid at the macula, detection and interpretation. There's an announcement from the organizers. Those who have not collected their ready reckoners, they may do so by showing their badges at the kit counter. The ready reckoner, which was released during the inauguration, is available from the kit counter.
like to thank Dr. Kumar for having asked me to talk on the subject of fluid at the macula, detection and significance. I really didn't know how to go about it because it's a potpourri of subject where I'll be basically reciting the various causes of fluid at various levels. But I thought I'll try to make it as structured as possible. I hope it will be giving you a coherent message. First, at macular evaluation, we know you already heard in the first talk, you can use various methods like indirect ophthalmoscopy, which is not the best option for evaluating the macula. The direct ophthalmoscopy is better than indirect, but perhaps lacks stereopsis. And slit lamp biomicroscopy has really the treatment is the way we go about it in the clinic. And contact lens examination always gives you better resolution than non-contact lens examination. OCT, of course, will give you a micron level resolution. This has already been dealt with, so I don't think I go into the details. Just to tell you that the outermost layer, which in the original status OCT was seen like one layer of retinal pigment epithelium, is now divided into 4 layers, including the external limiting membrane, the so-called ISOS junction, now called as the ellipsoid zone, and the interdigitation zone, or the previously called as cone tips zone, and the actual retinal pigment epithelium. So you see all the 4 in one single component. So coming to fluid at the macula, it can be located from outwards to inwards, right under the retinal pigment epithelium. I'm not still talking about the suprachoroidal fluid here. I'm talking about sub-RPE because we're looking at a small lesion area of macula. And then the subretinal fluid, which is between the retinal pigment epithelium and the neurosensory retina, the intraretinal fluid within the retinal layers, and a combination of the lot. We also would like to know what is the effect of vision of fluid at the various levels. If you have fluid at the subretinal pigment epithelium alone, you can see that the RPE and retina are in touch with each other. So there's no problem of communication between the two, and hence there's no effect on the vision, which is what you find in most cases of PED unless it's associated with other pathologies. But of course there can be distortion of the image because of the elevation of the fovea. While if you have subretinal fluid but with a healthy retina, like in a central serous retinopathy, again the vision is not badly affected unless the retina is grossly elevated when there is a problem of the RPE not being able to remove the metabolic waste products. But within the neurosensory retina itself, there's very good communication because it's a compact retina, and hence the visual acuity is usually well preserved, except that you may have to put a plus lens to get a 6x6 vision. In contrast, intraretinal fluid disrupts the communication between the layers of the retina. At the outer layers, bipolar cell layers, mononuclear cell, and the ganglion cell layer. And hence, you have the vision being disturbed. And the amount of vision disturbance is directly proportional to the amount of disruption of the interneurons, as we call it. So if you have a large cyst, which hardly any identifiable linear streaks across it, there's no communication at all between the two, and a lot of atrophy of the inner layers as well, then the vision is going to be quite poor. But you have lots of diabetic macular edemas or BRVOs where the patient presents with 6/9 or better vision, and you still see a lot of macular edema. That's because the interneurons are quite intact. Now let's talk about sub-RPE fluid. You can have the sub-RPE fluid, as the name indicates, is a fluid present between the Bruch's membrane and the retinal pigment epithelium. And we see this is a typical case of pigment epithelial detachment, and you really couldn't image the Bruch's membrane very well, but you can still get enough reflexes here indicating that this space is serous, it is not hemorrhagic. But if this was filled with hemorrhage, you find a shadowing effect because nothing will be imaged beyond the blood. And this sub-serous sub-PED space or PED space can be filled with serous fluid, as in this case, or it could be filled with fibrin or CNVM, as in the case of AMD, etc., etc. In this case, you have a shallow pigment epithelial detachment. See, the pigment epithelium is elevated, and you find that the sub-PED space is actually heterogeneous. It is not homogeneous. It is not clear. And this could be both fibrin and CNVM or a combination of that plus blood as well. You also see incidentally a subretinal fluid component here. Now this is a case of a large PED. You can see this pigment epithelial detachment, and you see a notching here, which is where you suspect the CNVM, and you see, of course, a small lesion here in the ICG, which is probably more looking like a polyp. And if you were to do a OCT here, you may find it just like a serous PED, but if you do it across this point, is where you will find the lesion in the sub-RPE space. So it's very important that you scan the entire area with the OCT and not just take one midsection and then come to conclusions. Now this is a case of, again, a shallow PED, and more obvious is, of course, the subretinal fluid, but you should be conscious of the sub-PED space problem here, which is the cause for the subretinal fluid. So you should not lose track of the cause and effect relationship. Now again, a sharp pigment epithelial detachment with a small bumpy pigment epithelium and a little bit of subretinal space fluid. But what you see is a multiple polyps and a large BVN here. But this section actually did not go through this polyp. It actually went through one side. And what you see here in this pigment epithelial detachment, just contrast the contents of this PED. I'm sure it's not blown up in good magnification, but it looks pretty clear. I compare that with this sharp PED, which is not clear. So this is more suggestive of a PCV, polyp lesion, rather than just a serous PED. So one of the differences is that a PCV causing a sharp elevation of pigment epithelium usually has got more heterogeneity within itself than a simple serous PED. Now here is a case of AMD with retinal angiomatosis proliferans, and you can see here that the pigment epithelium is detached, and you find that the proliferative process has stretched across the retina and reached up to the pigment epithelium, and hence pigment epithelium is detached. So if in stage 1 and stage 2 of RAP lesions, you don't get pigment epithelium involvement because it's still intraretinal. And once it involves the RPE, you find pigment epithelium can be detached. You can actually see the entire neovascular process is within the retina and hanging like a hanging drop into the sub-RPE space, with the rest of the PED being relatively clear. Coming to subretinal fluid, the next space beyond the pigment epithelium, it may have a thin film of fluid with an intact retina, as in a case of macular detachment in a partial recombinous retinal detachment. A residual fluid after RD surgery, which is very often missed unless you do OCT, you will find sometimes a small thin film of fluid under the macula, and you think the visual recovery is not good because it's a long-standing detachment or because macula was detached already, but very often it could be because of the residual fluid under the fovea. And in very chronic RDs, like in a lattice degeneration with an RD involved in the macula, that fluid may take a very long time to resolve, and even up to 6 months, you may find a small thin film of fluid on OCT. Central serous retinopathy is another typical example of a thin film of fluid with intact retina. A TRD that spreads into the macula, very often you can see the acute spike in the retina just beyond the macula where the fibrotic tissue is pulling on the retina, and then it comes down in a concave fashion, unlike a CSR or recombinous detachment where it's more convex. Secondary to tumors also you can have fluid, the hemangioma can be anywhere, and you can have a serous detachment. There can be highly elevated retina in the macula due to TRD and RRD, which I have already alluded to. What about subretinal fluid? Along with intraretinal fluid, you can see in a variety of conditions, mostly vascular retinopathies and uveitic conditions. This is a case of central serous retinopathy. You can see the fluid going under the macula, and the fluid is a little more towards the optic disc side on the papillomacular bundle side, but you see it's absolutely clear subretinal fluid. Clarity of subretinal fluid is not always required in CSR. As you see, in this case, this is also a CSR, but you see some fibrin. Fibrin does not mean it is always CSR, but you should be able to take other features into consideration before differentiating between CSR and a VKH-like response, because VKH can start with,
No, please continue.
Yeah. So this is subretinal fluid with fibrin and a bumpy choroid. You can see the choroid is bumpy. This is more suggestive of a choroidal inflammation caused by a VKH syndrome. Vitelliform deposits in the Best's disease, you don't get gross elevation, but it's important to remember that the deposits are subretinal and not sub-RPE alone. You can get sub-RPE deposits as well, but these vitelliform deposits are actually in front of the RPE. Intraretinal fluid, pseudophakic CME, uveitis, etc. And these are all self-explanatory, nothing much to describe, that there's fluid within the retinal layers and spreading it out. You can get a picture like this, you can get these hard exudates along with it. You can get also a subretinal fluid along with it. But related conditions, which is not really caused by exudation, is like macular myopic schisis. You can see the spread of the retina and interneurons also visible along with a small foveal detachment and a lamellar hole. A similar case of retinoschisis, you can see the split in the layers. You can get fluid in all the three spaces, as in this case, you can get sub-PED space, subretinal space, and intraretinal space. You can get fluid-like spaces. This is perhaps the last two slides. I'll close with that. You can get cavitational spaces in the mactal, or so-called PFT, and focal choroidal excavation and a trapped PF seal bubble. So one example of each. This is the parafoveal telangiectasia, so-called mactel, where you find a cavitation space. It's not fluid really, it's because of retinal atrophy that you get this. Contrary to a fluid, there's no elevation of the retina, it's actually thinned out. And this is a case of subretinal PFCL, where you can see it from the acute angle because you have the high surface tension of the PFCL, you find it has a very closely coherent bubble, which causes this acute almost 90-degree angle to the retinal pigment epithelium. And last slide, this is a focal choroidal excavation, which is a curiosity, where you find the choroid can be excavated at the foveal location, and very often you can see the retinal layers can be lifted off the excavation, and you will find a small fluid component under the excavation. Thank you very much for your attention.
Thank you very much, sir. Excellent. May I now request Dr. Guru Prasad to please present his talk on sheets and striae at the macula, what do they indicate?
Thank you very much, Dr. Kumar, for this opportunity, and especially for including me in a session where there are luminaries of retina in the country. I'll be speaking on sheets and striae on the macula, what exactly we have to interpret them as. Actually, sheets, striae we'll start with, and you see there's a wide spectrum of pathology that it represents in conditions where retinal redundancy occurs, where the retinal elasticity allows for microfolding of the retina, throwing them into corrugations. So it can vary from, as I said, there is a wide spectrum. It can vary from subtle striae to gross macroscopic striae, as you see in the slide on the right. So a taut hyaloid or a fine ERM can also cause striae. You can see these striae on the OCT corresponding to the striae here, which is very subtle and maybe needs a high magnification view. A case of VKH, Wood-Koenig-Herda syndrome, where there is a choroidal thickening, the thickening causing blunting of the choroid, rather the excavation or the normal contour of the eyeball is blunted there, and therefore the retina has a lesser area to fall back on, and that is thrown into folds, causing these corrugations or striae. These are cases which probably are dystrophic in nature, bilateral, symmetrical. These are striae which are circumferential, and these are striae that are almost horizontally, parallelly arranged. And these are probably cases of, we haven't made a diagnosis or haven't fitted them into any particular entity, but probably of dystrophic nature without any obvious pathology. Any push from behind, as for example in a orbital mass with indentation of the eyeball from behind, especially if it occurs at the posterior pole or eccentrically outside the posterior pole, can also result in striae like this, and we should have a high index of suspicion for these cases in which we find striae where there is proptosis and other signs of space-occupying lesion in the orbit. This is a case which my resident wanted to do neuroimaging for, striae at the macula and a disc edema like picture, and this was deferred for a week. The patient could not afford an MRI imaging of the brain, and therefore when he came back the next time, I looked at the periphery when the pupil dilated better than the previous visit and found that he had a choroidal detachment and he had a history of a post-filtering surgery. So I think we should also keep this in mind. A hypotonic maculopathy can cause striae and a disc edema. One interesting case of striae which I would like to share with you all is that of a doctor actually who had blurring of vision in one eye, that is the left eye, with reduction to 6/18 and N10. Fundus examination showed the typical post-viral neuroretinitis, not very well seen in this particular slide, but he had cottonwool spots which was not there before because he had been under my care for diabetic screening, and he had a normal retina. There was no diabetic retinopathy, and these cottonwool spots suddenly appeared and there were some hemorrhages, and we thought this was a post-viral neuroretinitis, which on IR imaging and FAF showed striae as well. And this was the OCT picture, retinochoroidal folds on OCT. This is something which we had never seen in a patient with striae, with history of viral fever and presenting with a post-neuroretinitis like picture. So this was something that we saw for the first time, and I would like feedback from the audience and the panel if there is time. This patient unfortunately was lost to the viral disease and its complications. Sheets are nothing but proliferations due to damage to the tissue and repair thereafter. The natural repair results in the epithelial membranes. A localized proliferation caused by tissue damage and subsequent repair which can be classified. We can use the classification of Ivanov, which is a spontaneous idiopathic ERM, or it could be secondary to vascular instability in certain diseases like diabetic retinopathy, Eales disease, hypertensive retinopathy, inflammation caused either by laser or cryo itself, or inflammatory diseases of the eye, or after trauma or retinitis pigmentosa. So the example of an ERM with focal attachments on OCT, or it could be an ERM with global attachment. So this is the spectrum I'm just going through. In the pre-OCT days, we used to think of treating macular edemas. All macular edemas we used to treat, whether there were membranes overlying the macular edema or not. We used to treat them with laser. And this is a patient who had 3 sittings of macular laser. And when this patient came years after, when the OCT was available, had this picture. So although the edema had subsided, there was a VMT, vitreomacular traction with grossly reduced vision, which improved dramatically after surgery. These sheets on the macula, the epithelial membranes, are also very well delineated by the OCT. You can see the sheet of tissue here, which is actually causing multiple focal TRDs. These are not to be confused with spongy edema or anything by the youngster. Remember, there are actually multifocal attachments on the retina causing TRDs. Surgery is usually indicated when the vision drop is less than 6/18, but in the present day where we are more aggressive because of the better instrumentation and the results that we have with the MIVS, we are operating on patients with just subtle symptoms, because the patient's symptoms can be very annoying for him in the form of metamorphopsia or uniocular diplopia. The surgical prognosis is better for idiopathic ERMs, and the first symptom that is relieved by surgery is metamorphopsia. He may not improve very much in terms of lines of vision. So this is just to show one more tool in our armamentarium, intraoperative OCT for the removal of these membranes, which we are able to do with more conviction and more accurately in the present day because of MIVS, because of staining techniques, and the latest because of the intraoperative OCT that we have in our armamentarium in the present day. And this is for the fibrous tissue. So in summary, I would like to say that be familiar with the causes of sheets and striae. OCT is definitely, clinically you have to examine, but OCT can always be used to confirm and quantify these lesions, and surgical results for these are excellent. Thank you very much.
Thank you very much, Dr. Guru Prasad. Batting lower down the order is that when the top order has really scored well, you have very few runs and a lot of overs to left to score the remaining runs. So I now have more than 10 to 12 minutes, so you must pardon me for taking more time. I will be talking on yellow lesions at the macula. As I had already alluded to earlier, these lesions can't be interpreted in isolation. We'll have to take the totality of the picture into consideration before we arrive at a diagnosis. But even so, we will see how, you see, the macula is the apple of the vitreoretinal surgeon's eye, and it can respond only in a limited number of ways to a plethora of clinical conditions. So, for example, it can manifest as A or B, but the A itself may have A1, A2, A3, slight variations, subtle variations in the manifestations, and we are trying to look at these subtle variation in manifestations to arrive at a diagnosis. Now, merely because they look similar, they need not be the same. And the retina responds in a limited number of ways to a variety of disease processes and insults, and the interpretation depends on associated findings, pattern recognition, and ancillary tests. I will go really at breakneck speed because I have about 70 slides to cover. Now, this is about clinical nuggets about yellow-white lesions at the macula. This is not an all-inclusive exhaustive list, as Dr. Gopal was mentioning. Now, we can classify it in various ways depending upon the etiology or the pathology on hand, or we may have a disease-wise classification, and in my talk I will try to have a combination of all the two. Coming to the commonest yellow lesion at the macula, hard exudates, these are waxy yellow, well-defined. They are more anterior in the retina and may take different shapes, and those are some of the commonest conditions. We have already discussed that. Maybe either focal, it may be diffuse all over the macula, or it may be just a small spot of hard exudates, which we should not be missing, or it may be a diffuse yellowing in the form of a diffuse macular edema. It's not moving forward? Okay. It can be associated with vascular anomalies in the form of arterial narrowing in hypertensive retinopathy, or it can be manifesting more after the acute disease process has resolved, as in this case of a post-viral neuroretinitis. After the initial lesions have healed, the hard exudates have become more pronounced. Again, a patient with anterior ischemic optic neuropathy, where the hard exudates are appearing as the disc pallor is setting in, and the hard exudates becoming lesser as the disease process gets better. So it can be either way. It can become more manifest as the fluid is getting absorbed, or it can also be that the hard exudates may disappear as the disease process is getting better. Have a look at these slides. This is a patient with IPCV who had a altered hemorrhage at the macula and active bleeding around it. He was treated with laser and the lesions disappeared. But what I want to draw your attention to is, I missed this early hard exudate here when he came for a follow-up about 6 months later, and 2 weeks down the line, the hard exudates have increased. So we must be ever vigilant to even a small speck of hard exudates, because that indicates activity. So the take-home snippets about hard exudates: do not miss early hard exudates, even if they are a small speck, which may occur if only indirect is used. And hard exudates may appear as the edema is resolving, or may indicate resurgence of activity of a disease. And if the hard exudates are more widespread and extending beyond the arcades, with a preponderance of flame-shaped hemorrhages and extensive in nature, one should always suspect the possibility of a hypertensive or a renal retinopathy. Coming to the next commonest cause, it can appear in the acute phase in BRVO or in the chronic phase in BRVO. But what we should be vigilant is to look at what was the ancestor of this photograph. Now, this patient who presents only with these hard exudates, this was the original picture. So we should look at other signs, telltale evidences in the form of sclerosis of the vessels or collaterals. And in this patient who was diagnosed as diabetic macular edema, there are no other signs of diabetic retinopathy in the fundus. You do an angiogram and you see these collaterals, and if hard exudates are restricted, these are some more examples of hypertensive retinopathy in the form of Elschnig spots and post-BRVO hard exudates. So look for telltale evidence of old vein blocks and learn to surmise the ancestor of the present picture. Hard exudates restricted to only one side of the horizontal raphe indicate an old BRVO. Hard exudates always need not be related to the disease that the patient has. This patient was treated with multiple injections of intravitreal anti-VEGF agents, non-resolving macular hard exudates. And when he came to us, we saw something here which looked like a macroaneurysm, although it was not showing up on the angiogram. We decided to go ahead and treat that because of its location. And lo and behold, we have a very nice picture of resolution. So the take-home snippet there is look for alternative causes in so-called refractory diabetic macular edemas. Again, hard exudates at the macula need not always be related to the disease process on hand. This patient was treated again with multiple anti-VEGFs without a proper diagnosis being made, and rather than reducing, it was only increasing, and there was also a submacular hemorrhage, and this patient actually responded to photodynamic therapy because the OCT and the ICG in that case showed a polypoidal choroidal vasculopathy. So the correct diagnosis and treatment will cause resolution of the hard exudates, not anti-VEGFs, given as a blanket treatment, and ICG and OCT will help in the diagnosis. Coming to hard exudates with paucity of hemorrhages, these are some of the causes. Now this patient who presents with hard exudates at the macula but no other signs had choroidal neovascular membrane, and that patient responded very well to anti-VEGF treatment. These are some more examples of idiopathic CNVM. One should not lose sight of the fact that when there are yellow lesions like this, there is something more yellow here which is of sinister nature, and that is early CNVM in this patient. Hard exudates in association with CNVM always indicate that the disease process is active in the case of CNVM. So associated signs and ancillary tests will aid in the diagnosis. Now, if you have hard exudates at the macula, the problem could lie elsewhere, as in these set of photographs: Coates disease with peripheral telangiectasia, or lesions elsewhere, capillary hemangiomas as in VHL syndromes, the problem may be elsewhere. So look elsewhere in the fundus when the macula itself is the sink for hard exudates. Coming to the different pattern, if you see the hard exudates in the form of a macular fan or a star, these are some of the conditions that you will have to consider. A patient with neuroretinitis or a patient with resolving retinitis post-viral, this photograph we saw earlier. And cotton wool spots are another cause of yellow-white lesions. The causes can be varied, myriad, but if you have a preponderance of hard exudates soft exudates or cotton wool spots clustered around the optic disc, it could be this is a patient with hypertensive retinopathy that resolved merely with control of hypertension. But if you have something like this, then you must consider the underlying causes such as acute pancreatitis, collagen vascular diseases, SLE, chronic renal failure, etc., particularly when they are confluent peripapillary yellow-white spots. Coming to the yellow-white lesions in CSR, I'm now going disease-wise. Now, they can be either the site of leak may look yellow, or there can be subretinal fibrin as the fluid is getting absorbed, or subretinal precipitates, or it could be the treated spot, or it could be chronic fluid subretinal fibrin, which is manifesting in this way. It can also be, CSR can also be, this is a rare picture in which a CSR in this patient was associated with drusen as well. So ancillary tests are very much required in these patients. So chronic lesions in CSCR may mimic CNVM and ancillary tests help. These are some of the yellow-white lesions, the discrete hard drusen in dry and the soft drusen in the dry ARMD, and of course the yellow lesions associated with hemorrhages, disciform processes, and after resolution of PED. These are some of the various ways in which yellow lesions in wet ARMD can happen. Inflammatory yellow-white lesions, some of the commonest causes are listed over here. It can be associated with no other pigmented lesion in the fundus. It need not always be a satellite lesion adjacent to a pigmented lesion. These are two examples of toxoplasmic yellow-white lesions that's resolving with treatment. Examples of infective causes in the form of tubercular choroiditis or sarcoid-related. This, of course, ancillary and systemic tests will have to be done, but I'm just showing these pictures so that you develop a kind of a pattern recognition to identify. This is sarcoid choroidal granulomas with optic disc involvement and resolution following systemic steroids. Geographic helicoid peripapillary choroiditis with associated other signs and pigmentation at the borders, or VKH, or APM-PPE. So the pattern recognition and systemic investigations in these will help. Coming to ischemic yellow-white lesions, we are all aware of these things, but I would just like to draw your attention to some of the subtle yellowing that may occur. Patient may complain of vague visual obscurations, and if you observe closely, you'll see an intravascular yellow lesion within the vessel, and that is the intravascular clot. As you can see on this picture more clearly, there are multiple of them actually. So these are things that should not be missed. We should not be missing the woods for the trees. And subtle yellowing of a sector may be missed. Look carefully for the emboli. Pressure over globe may accentuate the visibility of these. Some of the other conditions that can cause yellow-white lesions are metastasis, intraocular lymphoma, and endogenous endophthalmitis. Usually they are bilateral, multifocal, and you have pigmentary changes, what is referred to as leopard spot pigmentation, and they rapidly increase over time on follow-up, and they will be associated with a disproportionately large increase in disproportionate amount of subretinal fluid. Intraocular lymphoma, a stippled pattern of hypo and hyperfluorescence. So large nodular yellow-brown lesions with leopard spot pigment and disproportionate SRF are sinister. Rapid increase in a short time is a feature. This is about endogenous endophthalmitis. Coming to traumatic yellow-white lesions, altered blood can produce as a yellow-white lesion, and this should not be misinterpreted as something else. Berlin's edema, choroidal ruptures, and traumatic scars can produce as yellow-white lesions. These are some of the hereditary yellow-white lesions that we may see. Best disease presenting with an orange-yellow lesion, bilateral, and you will have to resort to an EOG to make a diagnosis. This is a familial form of drusen present both at the macula and in the nasal fundi. The other forms such as the Stargardt's disease, varying patterns, varying spectrum of Stargardt's disease, congenital toxoplasma, the macular colobomas, or parafoveal telangiectasias which may present as subtle yellowing, or some of these epiretinal membranes, etc., which Dr. Guru Prasad has alluded to. I will stop with this fundus picture. This patient was a patient of CA breast on systemic chemotherapy and presented with this subtle yellowing crystalline retinopathy. She was obviously on tamoxifen. So finally, close examination of both eyes is critical for the diagnosis. Thank you very much for your patient hearing. May I now request Dr. N.S. Muralidhar to please speak about his talk on blurred foveal reflex. What is the significance?
Thank you, Dr. Kumar. After a series of photographs like that you have presented to the audience, my photographs may look very, very nondescript. And that's the whole point, the blurred foveal reflex. First, let's understand what's the foveal reflex. We all know that foveal occupies 350 microns. In the center of the fovea is 150 microns of umbo, and this is the pit. The reflection from the concave surface of the foveal depression is seen ophthalmoscopically as a reflex. Anatomically, the fovea acts like a concave mirror. The fovea itself acts like a concave mirror. The incident light from your ophthalmoscope will get focused in the front, and then when you move the ophthalmoscope, the reflex moves in the opposite direction. So I think all of us, when we started doing direct ophthalmoscopy, we were all fascinated by the foveal reflex. I am sure all of us used to look at it more, with a lot of curiosity, and the foveal reflex was something that fascinated all of us. It's mainly because of this anatomical fact of the concavity of the fovea that you get that foveal reflex. And probably we used to see it more often with direct ophthalmoscope than with the indirect and the 90D, because you are examining a small area of the retina, and the reflex visible in that is much more, gathers more attention than when you swing a large area of the retina with an indirect ophthalmoscopy or with the slit lamp biomicroscope. Now, the fundus also produces other reflexes, not only the fovea. There are other areas around the disc in the posterior pole. These are exaggerated reflexes that is more often seen in young patients, especially hypermetropes. Probably the reason for seeing these is that there is smooth retinal topography, and the infant short eyeball, especially in children, has a plane mirror effect. So it's not unusual to see the reflexes in all these other areas of the fundus also. Now, what happens with age? With age, as we have emphasized earlier, the foveal, parafoveal, peripapillary reflexes get exaggerated. That's because the media are so clear and the light transmission is so good. Youth, only the foveal reflex is prominent. The other reflexes begin to become dull. And as the eye ages, there is a gradual loss of all foveal reflexes, partly because of the media. Media also become hazy. The lens loses its clarity, which was pristine in the early phase. Now, what can cause a foveal reflex to become blurred? Anything that alters the anatomy of the fovea, the concavity of the fovea, will cause a blurred foveal reflex. Now, we can classify them into three different conditions. Anything pulling on the fovea from the vitreous can alter the concavity and cause a blurring of foveal reflex. Anything causing the retina to swell up here, the fovea to become swollen, will again make the concavity last, and then that can also result in loss of foveal reflex. And anything pushing the retina choroidal complex and the fovea from behind can also cause a loss of foveal reflex. I think Dr. Gopal eminently displayed all these conditions which cause fluid and again loss of foveal reflex, because they cause swelling or pushing of the retina and loss of the foveal contour. Now, the loss of foveal reflex occurs in a variety of clinical situations that we all have seen now from the previous speakers: CSR, diabetic retinopathy, AMD, pre-retinal hemorrhage, drusen, etc. The point is, I'm not going to dwell upon any of these. The point, the conditions that I'm going to show you over the next 5 minutes or so
you have enough time. You can go at your own speed.
Okay. What I'm going to focus is on about some conditions in which the only clinical thing that you see is a blurred foveal reflex, and which is an isolated finding, and the rest of the fundus almost looks normal. Now that is when you really are beginning to wonder what is happening to this eye. So it's easy to diagnose the conditions here because there are other signs like the ERM here or the pre-retinal hemorrhage, retinal hemorrhages. So there you are concentrating on the disease as such. But some of the examples I show you, the blurred foveal reflex is perhaps the only thing that attracts your attention. Here is a 14-year-old girl. She's had history of poor vision from childhood, nystagmus. Best corrected vision is 6/24. You look at the fundus, you see that there's no foveal reflex here. Not only that, there's no fovea. When you do the OCT, you get the answer. We are not able to really image the fovea here, either in the right eye or the left eye. This is a foveal hypoplasia. So when there is no fovea, when there is no foveal pit, there is no foveal reflex. So a congenital condition in which the foveal pit is not there and hence there is no foveal reflex. So foveal hypoplasia is a congenital condition in which fovea is absent and therefore no foveal reflex is present. And it can also be seen as a part of ocular albinism. So in many eyes of ocular albinism, foveal hypoplasia is a concurrent feature. Here is an example of a person in third decade. The foveal reflex is blurred. If you see carefully, there could be some chytic cavities. This is a juvenile X-linked retinoschisis, foveal retinoschisis, which is picked up on OCT. Let me tell you one thing. When you see a blurred foveal reflex, don't think you will be able to come to a diagnosis just on your clinical examination. Today it is often difficult. It is only when we resort to imaging technology like OCT that we are able to really demystify what is happening. So today, if we want to diagnose a macular pathology or a foveal pathology, you need an imaging system like an OCT. I do not think you will be able to make a diagnosis in most of the instances without the help of OCT. 74-year-old gentleman, he complained of mild defective vision in the right eye. The foveal reflex is lost. I'm sorry for the quality of photograph. It is often difficult to reproduce what photographs we get in the hospital with the presentations. Sorry. And you see the subtle elevation of the fovea with the attached vitreous face, vitreomacular traction. Now, this is one condition in which I think OCT has played a crucial role in identifying this particular condition. Before the advent of OCT, I don't think we made a diagnosis of VFT or a vitreofoveal traction or a vitreomacular traction as much with our clinical examination. Maybe if we had put our fundus contact lens in every eye that we see, maybe we'll be able to diagnose this clinically. But today we don't have the time, and I think with the OCT, I don't think we need to do that. So VMT is one condition which can have a blurred foveal reflex, and OCT is definitely diagnostic, and then of course you need to advise surgery in appropriate cases. 60-year-old lady, distortion of images in the right eye, vision is still good, foveal reflex is not very obvious, and you see here there is an attached vitreous face there. So this is a vitreomacular adhesion as opposed to vitreomacular traction. The difference here is that there is no loss of the normal concavity of the fovea, and the patient's vision is often very good. You don't really need to intervene in these patients because they can maintain the status quo for long periods of time. Epiretinal membranes, I think Guru Prasad has already shows with sheens and folds ILM striae with loss of foveal reflex, and you see the epiretinal membrane with appearance of a side of either a pseudo hole or a lamellar hole-like appearance. Most often vision being good, you don't need to intervene in these patients. In my practice, I always struggle with the decision making for when to operate in a patient with ERM. Now you see the next example, you know what I mean. You see here 70-year-old gentleman, mild metamorphopsia in the right eye, BCVA 6/18. He also has some nuclear sclerosis. And this is a very common clinical scenario, patient having minimal cataract and some foveal changes. And often we are perplexed as to whether it's the minimal cataract that's causing the loss of vision or the foveal pathology. When you do the OCT, you find this, and you're nowhere near getting the answer as to what has caused the loss of vision in this patient, because most often you see many patients with this ERM with a minimal loss of the foveal contour with extremely good vision, good near vision, but maybe the distance vision is less. And here again, we are really confused as to whether we should operate on this ERM or send him to the anterior segment colleague for his cataract surgery. So sometimes the decision making in such situations, especially in a ERM, I often find it extremely difficult. And if I am not sure that the ERM is the cause for decreased vision, I don't hesitate to advise the patient to go to my colleague and have the cataract removed and come back to reassess to see whether he needs an ERM removal.
Yeah, I think
50-year-old lady, reading difficulty from the past
Murli, I
6
think
months.
They're saying that we have short time now. We are
Okay.
short of time.
Okay, I think those few slides. So we have a patient with, you see some glistening yellow crystals here. This looks normal. OCT, classic picture of loss of tissue here in the foveal region, showing a juxtafoveal telangiectasia. I think this may be the last one. You have, of course, CSR. We have all seen CSR. Loss of foveal reflex, elevation at the fovea, and OCT shows fluid at the macula. CNVM, a 68-year-old gentleman, he had undergone recent cataract surgery, recent drop in vision, 6/12. You see a subtle pigment epithelial change. OCT shows SRF. So blurred foveal reflex can be a common part of aging. It can also be a subtle sign in many macular diseases. It's possible that careful and diligent exam may give you some clues as to the diagnosis, but I think ultimately we all fall back on OCT to give us the required diagnosis. Even having the OCT, as I have emphasized to you, the decision making may not be so easy as to what to do with a patient, like in the patients with ERM. So with that, I conclude my talk. Thank you very much.
Thank you very much. I thank the audience and my colleagues for that interesting discussion. And I apologize to Dr. Gopal for the slight delay.